This is a conversation with Dr. Alexander Sack, Professor of Cognitive Neuroscience at Maastricht University in the Netherlands. Alex is a leading researcher and educator in the field of TMS. In this interview, Alex explains how our historical and current understanding of how TMS working mechanisms can help us to improve clinical benefits for our patients. By looking at the current brain state of the patient, his research is beginning to reveal how EEG activity showing a patient's real-time brain state can impact the effect of a TMS pulse. This, in turn, may allow us to harness the precise timing of TMS pulses to sync with a patient's fluctuating brain state. It's a fascinating look into the potential of truly personalized mental health care via brain stimulation. Here is our conversation. Hi, I'm Dr. Trevor Brown from Neurocare. I'm the Global Academy Manager and Neuroscientist for Neurocare. And thanks very much to Neurocare for sponsoring this. It obviously costs a bit of time and money to produce these, and we can bring it to you for free. So thanks for doing that. And this time allows me to speak with Professor Alexander T. Sack, who is a Professor of Cognitive Neuroscience at the Faculty of Psychology and Neuroscience at Maastricht University. Alex, thank you very much for joining me today. How are you?
I'm fine. Thank you very much. How are you, Trevor? Thanks for having me.
You're welcome. You're welcome. So you're in Netherlands, Alex. It's 9 a.m. I'm here in Melbourne. It's at 6 p.m. And it's actually the second time I've spoken with you, Alex. So thank you very much for your time. The first time we spoke, we got to know a little more about where you grew up, where you studied, some of your initial research. So if anyone's interested in seeing that first interview, I'm sure you'll find it fascinating, and you can go back and find out a bit more about Alexander T. Sack. We also spoke about some of your early research into transcranial magnetic stimulation, or TMS. And TMS is a treatment that's classically known for assisting patients with treatment-resistant depression. And in particular, Alex, we spoke about your role in developing new TMS techniques for personalizing treatment and trying to answer the question, and you elucidated this in your last interview, why patient A will respond to TMS and why patient B will not. And well, it's a question we pose throughout all of mental health care and throughout all healthcare for that matter, and all treatment modalities. Can we personalized treatment? And it's certainly something that we want to discuss in TMS as well. We finished last time by saying that we'd stay in touch, which we have, and help build a community of people interested in the TMS field. And as it turns out, we both continue to work in this field. Since the last time we spoke, we both conduct our respective courses and educate people on the latest evidence as much as we find the time for, which is what we're doing here today. So thank you very much for helping us to educate the field, giving up your time. We recently met Alex in London, and we decided to do a quick chat today, a bit of a history lesson on the working mechanisms of TMS, how our knowledge of those mechanisms have changed over time, and then we're going to use that knowledge to inform our discussion of your latest research on state dependence, brain state dependence in brain stimulation, entrainment and tuning effects of the brain, and how this might influence our personalization of treatment. And then finally, we'll give some practical advice on how to maximize the brain state of our patients before and during TMS stimulation. So we've got a lot to get through today. Sounds good. How are we going, Alex? Ready to get started?
Yes, I'm ready to get started. Yes, thank you.
Well, before we do, I've got a tricky question for you, because last time we spoke, I asked you a question regarding who you would invite to a dinner party. If you could ask anyone in the world, dead or alive, who you could invite to this dinner party, and you gave a great answer. And you told me last time I saw you in London that a few people had made a comment about this, that it stimulated a bit of conversation. What's happening?
Yeah, it was. I actually forgot about it because it was an unusual but interesting question you asked me. Very personal. I had to come up with 3 celebrities, people that I would like to meet to ask questions. And I think I answered back then was it Angela Merkel, the former Chancellor of Germany, Jesus Christ, and Elon Musk. Yeah. And that somehow, like from this interview about science and TMS and mental health, this is what people actually remember most. And they asked me, why would you meet that person? And why would you meet, what do you want to ask? So, and because it was a spontaneous answer at that time, of course, it's now in hindsight not always easy to explain what the rationale back then was. And I probably would invite different people now. But yeah, that was interesting for me to learn that people are very interested in these kind of questions.
Fantastic. Well, and you mentioned just then you'd probably invite different people, and I mean, and last time you spoke about Elon Musk, and you thought you wanted to look into whether he was a genius or just crazy, and you elaborated on that. Have you worked it out yet?
No, I think the verdict is still out. To be honest, no, it was just because he went, of course, he's very active in various fields and also in our field a little bit with neural implants and Neuralink and I saw some of the presentations. So I just would be interested to see what the plan really is and how knowledgeable he is on the details of the brain science behind it and the attempts to develop implants that could restore motor functions or visual functions. Because of course, I and many of our colleagues are also working in that field, and we have many difficulties and challenges to overcome. And I would be just interested to see in a field where I'm, have some expertise, then I could probably judge better how much is, a genuine, deep understanding of the challenges and what is a bit more marketing-like, high-level descriptions.
Well, I'd love to be at that dinner table or a fly on the wall just to listen to you actually speak to him about that. So, any more now? Any other people that come to mind? You mentioned now you might invite other people. What other interests have you got?
Yeah, no, I mean, I would probably. I mean, I don't know about Australia, but living in Europe, also the political climate is changing quite a bit. Also here in the Netherlands, we have a new government, so and the whole world is seem to polarize quite a bit. In left and right and up and down, and people have a hard time communicating with each other, which I think is very dangerous. Because even if you disagree on some aspects, it's important not to just have this in-group out-group feeling about everything. So I would probably invite people that are on the surface not aligned with my own ideas, just to have a civilized conversation about why they think a certain way forward is better than another, and then see where we find common grounds again. So
yeah, it's all about communication, isn't it, Alex, and understanding each other's perspectives. And that's a very civilized answer. Thanks, Alex. Okay, so I just wanted to lighten the mood a little bit before we get started, and before we get into the nitty gritty of TMS, and really what we decided to do was give a little bit of a historical overview of this asymmetry hypothesis of TMS, long-term potentiation, that activation, deactivation theory of how TMS might have been working. So in a nutshell, I mean, I've interviewed Leo Chen from Monash University, and he gave a very in-depth explanation of this already. So those who want a more in-depth explanation can listen to his interview. But in a nutshell, what did we used to say, Alex?
Well, it's a very good question. And it's a question that is still actually from the beginning of TMS, more than 30 years ago until today, still a relevant question. That is the question on a neurophysiological level. What is TMS actually doing to the brain? What happens to neurons that are exposed to an induced electric field by applying magnetic pulses to the brain? And there's a lot of research, mainly on the motor cortex. And they're based on that early research, we have a certain idea, or we used to have a certain idea, what applying a TMS pulse will do to the neurons in the motor system. And we considered TMS to be able to trigger action potential, to always stimulate. And if we apply it repetitively, so the so-called rTMS protocols, which are the reason why we are talking about this method today. We have this idea or concept that if you apply repetitive TMS pulses, thousands of pulses with a certain frequency, measured in hertz, that you can actually induce neuroplastic changes that are outlasting the stimulation itself. And there's still, also in psychiatry, the idea is that you could use so-called low-frequency protocols, 1 hertz RTMS, for example, to induce inhibition, to lower the excitability of the stimulated area, make it less active. That is a bit the metaphor, versus using the same equipment in the same patient, but now changing the frequency to high frequency. Classical 10 or 20 hertz protocols would do the opposite, would do increase excitability, cortical excitability. And we explained that by triggering processes of long-term depression and long-term potentiation. That is the model this is all based on. This is the model that we use to choose a given protocol for treating a certain disorder. And even though that is historically how it all happened, we now know that things are far more complicated than that. What I just said is simply wrong in its simplicity. We do know now that you cannot make such a conclusion for an individual patient because there is quite some individual differences. How a given brain will react to a certain RTMS protocol frequency. We even know that the same patient that responds to a low frequency protocol with inhibition, like we want it, would change to facilitation just by changing the intensity of the stimulation. So there are a lot of nonlinear dynamics which questions this entire universe of this wonderful conceptual framework that we still use in psychiatry, that low frequency protocol will lead to inhibition and high frequency will lead to excitation. So things are more complicated like that, but still we are using this dichotomous idea because it is so useful for us to select a therapeutic protocol to treat a certain disorder. And we continue doing this, and the funny thing is we continue doing this successfully. This is one aspect of my answer. This is purely about the neurophysiological mechanisms of TMS. I'm not even talking about the prefrontal cortex or depression therapy. I'm talking about fundamental understanding what applying a TMS pulse to the motor system, because there we can study it the best, because we have readouts and we can look at this. So most of our fundamental understanding of what TMS does to the brain is based on investigations in the motor system. Even this is now showing us that things are far more complicated than the old LTP, LTD-like idea. And now comes the second level of your question, that is that even if we ignore this problem, that our neurophysiological models are oversimplified, and let's assume they would be true, even then we are facing another dilemma that historically the therapy for treating depression was based on an assumption that there is this asymmetry in activity between the left and the right prefrontal cortex, with the left being hypoactive, so not active enough, and the right being too active, so hyperactive. And because of that idea, which is now also probably false as a statement as general as this, and there is actually not so much empirical evidence backing up this simple prefrontal asymmetry hypothesis. But based on that, people then still used to develop therapeutic protocols that would address this prefrontal asymmetry using a high frequency protocol on the left to increase the activity in the left hemisphere of this assumed hyperactivity, using a high frequency protocol from which they assumed it would always be excitatory, which I just said is also probably too simple of a statement. Or as an alternative, many clinics also use a low frequency protocol on the right hemisphere. So this is how historically we chose those protocols for those targets to treat depression. And although, let's say, from the historically and conceptually that makes a lot of sense, based on everything we know now, this actually is at least built on two very questionable assumptions. This is what we know now. This is where we are now. And still, besides all of this, you could say as a clinician, I don't care, because doing this for the last 20 years has led to response and remission rates of between 20 to 50% in patients suffering from treatment-resistant depression. So even though we might have developed a protocol based on a wrong assumption, using a protocol that is one size fits all, that's probably not doing justice to every individual patient, on average, we had absolutely amazing clinical effects in a population of patients who don't respond to any alternative treatment, which justifies its regulatory approval by the FDA, which justifies its use in clinical practice and the reimbursement by health insurances, which I fully support. But we now are at that moment, at that crossroad where we need to figure out what's going on with a very good probability that if we do figure out what's going on, we will increase those response and remission rates for our future patients dramatically.
Yeah, really, really well articulated there. Thanks for that background, Alex. And it's amazing that we've got a TMS treatment or intervention here that is so successful in a generally hard to treat population. We're learning much more about the working mechanisms of how TMS works, and that's what we're going to delve into a little bit more together today. And we're starting to learn a little bit more about how those TMS pulses are actually acting on the brain, and that it's not so much a simple activation of one side or the other, asymmetry. It's potentially got something to do with the depression network and the different parts of the brain that are connected to each other in the depression network. There's one part of the prefrontal cortex, and you mentioned the prefrontal cortex before, and TMS pulses are generally targeted on that prefrontal cortex, a place called the dorsolateral prefrontal cortex, or DLPFC. And we know from a lot of neuroimaging that it's highly connected to a place called the anterior cingulate cortex, or more precisely, the subgenual anterior cingulate cortex. Would you like to just elucidate for us a little bit about we're starting to understand about connectivity in the treatment of depression with TMS?
Yes, of course. So indeed, like you said, Trevor, many of the therapeutic protocols using TMS for depression, but also all the other indications that are under investigation at the moment, like OCD, PTSD, neuropathic pain, epilepsy. There are so many potential candidates that can be treatable with non-invasive brain stimulation, with TMS. And if you look at those protocols that seem successful or promising, they all always have similar targets. It's always the dorsolateral prefrontal cortex, or the primary motor cortex, or the supplementary motor area, or the parietal cortex. And people always ask me, like, why are those regions so relevant? Why are all these psychiatric and neurological disorders all localized in those same regions? How is that possible? And the simple answer is what you already indicated, is that it's not those regions that are relevant as a local region, not at all. The reason why we target those is simply the result of the limitation of TMS as a transcranial non-invasive brain stimulation technology, which uses magnetic pulses that are painless and that can go through the skull without distortion to induce an electric field in the brain that triggers then an electromotive force and as a consequence electric current flow, so it makes neurons fire. And it can do so within the induced electric field, but because of the physical properties of the magnetic field getting weaker with every millimeter distance from the TMS coil that's placed on the outside of the patient's head, we are limited in our direct stimulation effects to the neocortex. And that's why all of those protocols have as an initial target a cortical region. So we use those cortical regions to get to the actual more interesting, deeper lying structures, which we cannot directly stimulate because they are too far away from our TMS coil. So we use that trick to find a cortical entry, a window into a network. So it's always about networks. And that's, of course, how the brain works. The brain is comprised of regions that form networks flexibly, can actually change different networks. The same region can, from moment to moment, depending on the task demands, be connected to different subsets of other regions to form network A and then switch to network B. This is the highly dynamic network connectivity of the brain, how our brain functions. And depression, obviously, is a disorder with various symptoms and heterogeneity, and many networks are affected in depression. So there's not one depression network, there are several networks that are affected. And we have a better and better understanding which networks are those that are affected by a patient suffering from depression. So what we do is we use this very popular target in many protocols, the dorsolateral prefrontal cortex that you mentioned, because it's so highly connected to so many different regions that are deeper in the brain, that are part of the emotion regulation network, that are part of the cognitive control network, that are part of the limbic network. And by using this as a target, we get to these deeper lying structures. And indeed, like you indicated, over the last 20 years, there's accumulating evidence that there apparently seems to be a very specific connection between the dorsolateral prefrontal cortex, which we can directly target, to the SGACC, the subgenuine anterior cingulate cortex, and that this functional connectivity, for some reason, seemed to be quite a relevant pathophysiological marker of the depressive symptoms. In other words, there are studies suggesting that if TMS is successful in improving the clinical symptoms of depression, making a patient better, is usually then the case if in hindsight you successfully modulated the connectivity between the DLPFC that you stimulate and the deeper lying SGACC. If you did that successfully, then people got better. And if you failed to do that connectivity modulation with your TMS, for what reason ever, people don't get better. And based on this knowledge now, and this is probably also where you would like to move the discussion at that point, based on that knowledge, we are now for a couple of years already at the point where people try to personalize the depression therapy in such a way that they're not just simply putting the coil somewhere above the DLPFC of a given patient. No, what they do first is they put that patient in an fMRI scanner using a sequence and an analysis approach that allows them to determine which exact spot within the DLPFC of that patient is most anti-correlated to the SGACC, in a way identifying in an individual brain the perfect spot that is connected to the SGACC, and then place the TMS coil above that personal target to maximize the likelihood that the TMS therapy that is then applied to that personal target spot will lead to the modulation of the functional connectivity between those two regions. And because of this, will also lead to much higher response and remission rates in more patients. And recent studies actually indicate that this is also the case, so that we can increase the response and remission rates in patients if we don't think about the asymmetry hypothesis and just stimulating any point within the DLPFC, but rather position the coil such that we are maximizing our chances to modulate this network connectivity.
Yeah, beautiful. That's great, Alex, and really what we're learning and learned from the Stanford neuromodulation protocol as well, and the interview I did with Nolan Williams elucidates that a little bit more in depth. But we are starting to understand the particular spot where to target the TMS pulses to get that connectivity. What I'd love to speak to you about, and which is really your speciality, is that it's not only the localization of the TMS pulses on the cortex, which is important, but it's also the frequency of stimulation, which is important, which could be important for this particular person in order to disrupt the connectivity between the DLPFC and the ACC. And you recently co-authored a paper that just came out a few days ago. It was authored by Helena Voetel and Martin Arns as well. It was entitled, "Does 18 Hertz Deep TMS benefit a different subgroup of depressed patients relative to 10 Hertz TMS? The role of individual alpha frequency." So this paper really is looking at the influence of different people's own brain state, their own cycling speed of alpha EEG, and also the speed at which we send those rTMS pulses into the brain. And this might actually have an effect on that clinical outcome and how much we can actually disrupt the cortical network that we're targeting. So would you like to just tell us a little bit about that paper and where that's leading us to?
Yes, my pleasure. Before I do this, I would like to make clear that although I'm an author on this paper, this is not my work or my idea. That is really the work of Dr. Martin Arns from the brain clinics in Nijmegen, and I'm cooperating with him on various projects. But the credits for that go fully to him and also to his clinical cooperation partners that already implement some of those findings in clinical practice in some clinics in the Netherlands. So if you want to have a real detailed discussion about this idea of stratifying patients to different protocols, you should talk to Martin Arns about this. But I think his idea is very practical. So he builds his idea on the fact that we already have a couple of different protocols from which we know that they are clinically effective. I mentioned this in the beginning. There's not just one depression protocol that has been tested and actually approved to be effective clinically. There are 2 or 3 different protocols. And in the courses that I teach in the international TMS certification courses, I get practitioners from all over the world learning about these protocols. And some of them I know for some practical reasons or personal preference use protocol A or protocol B, and they all have good results on average. So the one clinic might love to apply always a 1 Hertz protocol to the right DLPFC as a completely fine and recommended and approved protocol to treat depression, while another clinic always offers a 10 Hertz high frequency protocol to the left DLPFC, again based on that probably false assumption of that prefrontal asymmetry. But clinically, it works. So Martin Arndt's idea was, why should we leave that up to chance or personal preferences, whether a patient gets protocol A or B? Can we not find some sort of biomarker that helps us to stratify a patient to one of those existing protocols? So he doesn't want to invent a new protocol. He wants to build on existing and effective protocols, but is want to choose which of the 3 available protocols is optimal for that given patient. And that is the $1,000,000 question. Can we say that, we can always find out post hoc? That's what many do, right? You offer, that's what we recommend in our courses also. You start with one protocol because you don't know before whether it will work or not. If it works, you've done the right thing. If it doesn't work, you can discuss with your patient to move to another protocol and see whether this works. And we have data showing that in some patients, this is doing the trick. We started with the wrong protocol, which we couldn't know, but then we switched to a second protocol, and now the patient is getting better. We even have alternative targets now outside the DLPFC And we have data showing that for some patients, the DLPFC is the wrong target in depression. And we have data recommending even alternative targets. But it is a trial and error procedure. You need to start somewhere, and then you move to the next one if it fails. So the stratification idea is to get some sort of predictive biomarker into that mix that helps you decide better. And there is this early work. It's preliminary, if you ask me still, but promising to use the EEG of a given patient to determine the individual peak alpha frequency. It's a simple procedure. You can measure the alpha frequency in each patient. We all have somewhere between 8 to 12 hertz is our individual alpha frequency. So it's an individual marker. And you can analyze, at which frequency is your alpha oscillating. Trevor might be 11 hertz and Alex might be 9.8 hertz. And that's our individual alpha frequency. And then there's data indicating that if you are around 10 hertz as a person, then a 10 hertz protocol could be a good option for you to use as a first protocol, because that might be the most effective protocol for you. And if you are lower than this or higher, they assign those patients to either a low frequency or in that case an AT or high frequency protocol. And by doing this, they had average response and remission rates that were slightly higher as compared to not just leaving it up to chance. So that's the idea of that paper. This is something that should be replicated, and of course, ideally, you would do that not in hindsight, but before you offer the treatment. But I think this way of looking at the things to instead of a full personalization, find some sort of stratification, do subgroups of patients is probably a good intermediate step before we come to fully personalized therapies.
Yeah, fantastic. And so your involvement in that research, I mean, I know you have a lot of background in electroencephalography, EEG, and it's great to have your knowledge in this area of personalization with EEG, not only because it could be very powerful at helping us to improve the likelihood of response, but secondly, because EEG is applicable within a clinic. It's actually quite practical to do on a daily basis within a clinic, and it's quite cheap relative to functional MRIs. So the potential for dispersed use throughout the world is quite high. So this is a sort of a background on where the field is moving in terms of personalization. Alex, let's now talk about some of the stuff that you're doing. It's really interesting. I heard you talk in London about the entrainment and tuning of the brain and the current brain state that this person is actually displaying, and how that results in different activation of the brain after TMS pulses and the different timing of those pulses. So would you like to tell us a little bit about what you're doing at the moment?
Yes, it's my pleasure. So as you already mentioned, and I fully agree, that's actually my mantra, is that in our attempt to improve the efficacy of TMS in depression and to personalize it, I feel that the entire field is at the moment too much focused on improving the positioning of the TMS coil. So like you mentioned, the connectivity-based targeting requires an fMRI scan and a resting state function connectivity analysis, which is complicated. It requires neuronavigation to have the perfect, precise positioning and real-time correction of the TMS coil to the personal target. And all of this is good, can't be bad, and I'm all for it. But it creates a barrier for many practitioners to actually implement in clinical practice. It makes TMS a complete new ball game, if you will. And that's what I mentioned in London. We have to be very careful if this is what we want to recommend as a new standard, because I think one of the reasons TMS has been so successful and has changed the lives of so many hundreds of thousands of patients worldwide is because although the neuroscience is complicated behind it, the practical implementation is rather simple. you need just a TMS device, which of course is an investment, but for the rest, the positioning and the protocols, even though one size fits all, is quite doable. Also for a private practitioner, a psychiatrist somewhere in a private practice, which is happening and which is part of the success. So if we now say that, well, this is the old way of doing TMS and the new way always requires an individual fMRI brain scan and this particular algorithm patterned analysis of where to stimulate and a neuronavigation system, we will decrease the accessibility of TMS. And if it's needed, it's needed. Then I'm the last one to be in its way. But this is the big question. To what extent is that personalized targeting, this precision TMS when it comes to the wear of TMS, really the only crucial ingredient we can work on to improve efficacy and personalize the treatment? TMS itself is not a very precise method. The TMS coils are huge and the electric field have a spatial topography. So it's not that you can stimulate a specific spot with high spatial resolution. That is just the physics make this impossible with TMS. So in a way, it's at least worth also looking at other ways of improving efficacy and personalizing TMS. And this is where we are working on quite a bit. And this is that not only the where of TMS is important, but also the when and the how of TMS, as I call it. And this means that you need to stimulate, or you have to apply the pulses at a certain momentary brain state of the patient. And there are different levels to approach this. And the most complex one, but also, let's say, promising one, is that we talked about oscillations before, right? The brain rhythms, using EEG to measure brain rhythms, like the work of Marta and Arns with the stratification. Our approach is a bit different than this because your brain rhythm and my brain rhythm is constantly changing from moment to moment, right? Our alpha rhythm, theta rhythm, and we can measure this with EEG. And this rhythmic brain activity you can index in its strength, its amplitude, which is the power or the amplitude of a certain frequency in your brain, but also the phase, which is the moment along the cycle of this oscillation, right? Is it at the peak? Is it as a trough of that oscillatory up and down of neural spiking, or is it somewhere in between? We call that the phase of oscillations. The power and the phase, these are important parameters. And now comes a very crucial finding that we know for a long time already. We know that we want to modulate networks. We just said that at the very beginning of our interview. We even know that there's a particular connectivity between the DLPFC and the SGACC, which needs to be modulated. The communication between the two needs to be modulated in order to have antidepressive effects. So we try to do that by finding the perfect position. But as a matter of fact, the brain communicates with each other within the networks via oscillations. That's the language the brain networks speak to communicate. So if the DLPFC wants to exchange information with the SGACC, it will do so not in the temporal domain by phase locking or synchronizing their activity rhythms. So you cannot ignore the rhythm if you want to improve communication in a network, because you would ignore the language of that inter-area communication. So what we developed is a way where you can apply the TMS pulse synchronized to the oscillatory brain state of a patient. So you measure with EEG the moment-to-moment fluctuations of the brain rhythm that underlies the communication, and you always apply your TMS pulse at the perfect and optimal oscillatory state that will maximize your chances that this TMS pulse actually is propagated to the SGACC and is modulating this connectivity. We call it oscillatory state-dependent TMS, which requires a sort of closed-loop protocol, and it sounds a bit technical, but in principle, a solution for this could be also a simple EEG TMS combination, which you just mentioned is in principle, in terms of barrier, doable also for a private practitioner. But then not as doing an EEG measurement before TMS to stratify to protocol A, B, or C, what the paper of Martin Arndt did, but actually using the momentary EEG of the patient during the TMS session to trigger your TMS to give phase-specific TMSs and therefore to optimize the effects of your treatment on the network that you want to affect. And we believe by doing so, you will probably address the big problem. The elephant in the room of all of these TMS approaches is that there is so much unexplained variability between patients. Why does it work for patient A and not patient B? And why does it sometimes work for patient A on one day, but not on another day? And I think reason for that is that we don't control the brain state at which we stimulate. And we know that the actual effect of the TMS is always a combination of our external stimulation and the internal brain state. They two are interacting and they produce the net result of the stimulation. So if you optimize only on one side, you will never have full control of the variability. And this is why I think this state-dependent TMS could be at least another, maybe easier way to personalize TMS than just to focus all our intellectual power on neuronavigation and precision of the location.
It's fascinating, Alex, and it opens a lot of potential and a promise for personalization of TMS. So not just in localization of the coil, but actually the how and the when, as you say, and the frequency of TMS pulses, and the brain state of the person, and how often that it fluctuates, how it really is very dynamic. So if we can have a closed loop system that's recording that EEG and apply our TMS pulses precise moment at, for example, is it a phase of oscillation that's going up, or is it the top of the amplitude oscillation, or is it at the bottom? Is there a possibility for us to get it wrong and decrease the effects of the TMS? How does that work? I mean, it's a very precise sort of timing that you're talking about, 10 times per second.
Yeah. No, these are the million-dollar questions, but these are empirical questions that we are addressing at the moment. The good thing about TMS is, and that's, to come back to what I said, if you look at the physics of TMS, what it is, electromagnetic induction, what we can never solve is that TMS is not a spatially specific method. It will never be. It's a magnetic field that is unspecific, and with larger coils to get deeper, also the field will get deeper, or the field will get more diffuse. So that's a limitation. But at the same time, we try to optimize this by navigating to a sub-millimeter precise point. But the temporal resolution of TMS is extremely high. A pulse is, has its, if you apply one TMS pulse, the peak of that pulse is reached within 100, 200 microseconds. So the whole pulse is probably less than 1 millisecond. So you could actually give those pulses at precise phases of any ongoing oscillations. And if you then even want to apply a repetitive, you can even let go of the idea of a 10 Hertz protocol. It could be a bit of a flexible repetitive stimulation at a given phase. But even if you want to stick to that low, high frequency dichotomy, which I criticized in the beginning, you can still do this and just jitter a little bit, depending on which frequency you, as a communication carrier frequency you want to use, jitter it a little bit and still be within a certain frequency range. And then do your classic repetitive protocol that is optimized in a closed loop system to always be applied at a given phase. Which phase that is, which frequency that is it alpha, is it theta, is an empirical question we can address with the current setups that we have.
Wow, the advances in technology and imaging are allowing these more precise types of personalization, which is brilliant.
But is the MRI itself, the fMRI, can have a very high spatial resolution. So that's not the problem. They will give us like is definitely with an MRI, also sub-millimeter precision, they give us a point. But no matter how specific that point is, the induced electric field will never be at a point. And therefore, the method itself is just not, people cannot conceptualize TMS as a way to stimulate a very specific point in the brain. That's just against the physics of TMS. That's why I'm saying, like, okay, then, and again, I'm oversimplifying, because there are people showing that it matters if you move the coil a few millimeters in one direction, and it's all explainable by the electric field modeling. So I'm not saying that it's completely unspecific and makes no sense to do that. But I'm saying it is funny that if you look at the physical properties of TMS, that we're not taking much more advantage of the objectively high temporal resolution of TMS, but we focus on the spatial resolution, which has its limitations in the physics.
Alex, look, if you were to take what you know about brain state and alpha oscillations and how they dynamically move in your patients and your participants for these experiments, what sort of take-home message would you give in terms of practical advice for psychiatrists and nurses who are dealing with TMS patients every day? They're delivering these TMS pulses. The patients are walking in after potentially bad night's sleep, lots of caffeine, different concoctions of medication. They might be feeling very good on one day, very poorly on the next. They might also be wanting to do different things during the actual TMS administration while the TMS pulses are coming. Are there any sort of things that we know on a practical level that we can do to optimize the benefit of TMS practice as it stands today?
Yeah, it's an excellent question. So while I still hope that the future will be more on rhythmic, non-invasive brain stimulation, and the whole ideas of modulating the individual rhythms via entrainment, which we unfortunately had not the time to dive into, but this is something that I find promising, that you can do rhythmic TMS to increase the individual rhythmic activity of someone's brain with clear therapeutic effects. You can even change the speed of someone's brain rhythm, make it slower or faster with external rhythmic brain stimulation, be it TMS or transcranial alternating current stimulation. And by changing the speed of pathologically altered neural oscillations, you can also have beneficial effects on clinical symptoms and cognition. So I think this is the future, and together with this, as I said, at one point, hopefully we will have these closed loop systems that allow you to combine EEG and electric or magnetic non-invasive brain stimulation to build on these closed loops, momentary, optimized, adaptive protocols. But they are not available yet, and we haven't answered all the empirical questions. So, and your question was, what could be a practical solution to this? I mean, if you don't have yet full control over the momentary brain state, what you could at least try to do is to not leave it completely up to this random fluctuation that you just described of completely different states in which a patient enters your clinic and gets the same treatment. So you can try to control it to some extent. And here in the Netherlands, by Iris Dahlhausen from Maastricht University in Nijmegen, they're starting a new clinical trial where they want to investigate whether a standard TMS depression protocol with uncontrolled brain state is less effective as the TMS depression treatment when you give your patients during the TMS some sort of emotion regulation training based on a computer task that activates a certain network in all of your patients while they're receiving the TMS. So in a way, even though you still cannot be sure that it will activate the exact same network in each and every patient, there will still be differences. You at least have some sort of simple, practical way to control it a little bit in your patient population, and definitely within the same patient coming for several sessions. And we will start this trial beginning next year. And then the question is that simple way of controlling the cognitive state of your patient during TMS a meaningful way to to increase clinical outcomes? And if so, that could be, again, an intermediate step before we go to fully closed loop state-dependent stimulation.
Yeah. So Iris Dalvisen, I know the clinician and researcher you're talking about. She's highly involved in TMS practice and controlling the person's brain state, and they've also done research on looking at psychotherapy simultaneous to the TMS.
Yep.
There was over the past 5 years 1 or 2 papers that came out about doing psychotherapy simultaneously to TMS, and potentially, if it wasn't controlling emotional state, potentially it was activating the brain to a certain extent through the psychotherapy and potentially keeping the brain active. So if we talk to the way TMS is generally delivered today, it's by nurses who would be stepping outside the boundaries of their professional competence to deliver psychotherapy at the same time. However, it potentially is within their competency and their boundaries of professional activity to discuss certain things with the patient, keep their brain state active, and potentially keep their brain state consistent throughout a TMS session. So given what you know about alpha oscillations, the power of alpha oscillations and how they change, as we both know, alpha tends to decrease in amplitude as we have an active brain state. As we get tired, our alpha amplitude increases, and that may affect, obviously, the timing and the optimization of the TMS protocol. This is all hypothesizing, this is all assumptions, but would you say, generally speaking, that we should try to keep the brain state of the patient active during a TMS session rather than letting them, for instance, watch TV or look at their phone or doze off?
Yes, although it's speculative because I don't have strong data to back it up, my gut feeling is yes, I would agree with you. And you could take it to the extreme. I mean, we have data from a very old study that was published in Science where they applied TMS to the brain and they used EEG to track how it propagates through the brain, right? So normally you give a pulse and it activates the area that you stimulate, but then if the brain is connected and active and conscious, ideally, this energy that you put in one area of the brain should lead to activation of neighboring areas, and then that should spread to connected areas that are far away, even crossing to the other hemisphere. And this is what you see in your and my brain. If we are both conscious and awake, and I would apply TMS pulse to your brain and to mine, we would exactly see this, picking it up with EEG over time, how in a few hundred milliseconds this activity that was induced in one particular spot would spread across the entire brain as a sign of the connectivity and the active state of our conscious mind. Well, they did this in that article at different states of consciousness. And they saw that in certain phases of sleep, the TMS pulse being applied to a sleeping person will not trigger this propagation of spreading within the network because it's a different state of consciousness. So, and if we now say that we want a spread within a network because it's the depression network and we want our TMS from the DLPFC to travel to the SGACC, and we know that this traveling of the TMS pulse will be highly limited during sleep, then you could safely recommend that for sure the efficacy of TMS is very likely to be less if you applied TMS to a depressed patient that's sleeping, which is an extreme case of what you just said. And if that is true, maybe, and that's speculative, everything in between is also true. The more active, the less amplitude of the alpha because you're cognitively engaged and active, because you do a task, a working memory task, an emotional regulation training, which keeps you active. Maybe that is a good brain state for TMS to work as compared to brain state where you doze off. but we need to have the data in a head-to-head comparison of the two to show that. The psychotherapy study, where I also was a co-author, is a very nice feasibility study that you could even do psychotherapy on TMS, but unfortunately it was also hampered by a lack of a comparison to how effective is it if you don't do psychotherapy at the same time. And we need those kind of studies to really make strong and firm recommendations.
Yeah, absolutely. Look, I've used up enough of your time, Alex, and you've been very generous to talk to me today. Thank you very much. Anything you'd like to say in conclusion, just to sum up a take-home message to anybody listening to you and the work you've been doing recently?
No, not necessarily. Just that maybe if we do a third interview, which I would be happy to do, you can invite me to Australia and we'll do it in person in a studio.
That would be wonderful. It'd be great to see you again shortly, Alex, and good luck with all your research. Your input to the field is invaluable. So thank you to you and all your work. Love to speak to you again in a couple of years and get another update, or hopefully sooner, maybe.
Excellent. Yeah. Thank you very much, Trevor. It was a pleasure talking to you. Thank you.
Thanks for your time, Alex. Bye.
Bye.
Work in the mental health field, or you're a budding researcher in neuroscience, you might be interested in some of the other conversations I've had with other experts in the series. Please like, subscribe, and let us know what you think in the comments.